I'm Jeff Spillane, one of the surgeons at Cape Cod Hospital. I'm joined by Dr. Michael Ayers, interventional pulmonary medicine, and Joan Macallister, who's a thoracic nurse navigator with our program. And as part of our team, we're happy that you're joining us. This is November, which is Lung Cancer Awareness Month. Our webinar tonight is on early detection for lung cancer, and wanted to go through some of the latest advancements and the benefits of lung cancer screening. So just to outline what we do as a team, our job is to find cancers as early as possible. Specifically, lung cancer is what we're talking about tonight. We're part of a much larger oncology team, and we wanted to go over lung cancer screening. We also find a bunch of things that we didn't expect when we do that screening. We review things through a lung cancer conference. We have a multidisciplinary conference every week, which includes oncology, radiation oncology, pathology, radiologists. We have social services available, and we also participate in that. Our job is really to get from an abnormal scan to an expeditious workup as quick as possible. And a lot of that facilitation is in large part thanks to Joan. We'll go over some of the diagnostic testing that we do, CAT scans and PET scans. And then Dr. Ayers will talk about our biopsy techniques that help us go from an abnormal CAT scan to tissue diagnosis. We also partner with Dana-Farber, their thoracic oncologist, team with us on the Thoracic Oncology Conference, and we try and engage the formal oncology team as soon as we've identified a problem. So the good news about lung cancer is that the rates are actually dropping and have done so for a number of years. If you look at the peak rates, the top slide is men, and the women's slide followed with what was called the Virginia Slims bump later, and that peaked a number of years back. There's a large lead time between smoking and then the development of a lung cancer. So people who were smoking in the 40s and 50s then would show up with a cancer, say, in the 1960s. The reason that lung cancer rates are dropping was because although we looked at screening early, it was felt to be much more cost-effective to go into smoking cessation programs and smoking prevention. That's when the warning labels started to appear on cigarettes, advertisements, and actually it was very effective technique to get people to stop smoking intake. Lung cancer still, however, remains a very lethal problem. It's still a very large problem in this country, and that's what we're here to help. So even though those rates are declining, now we're really trying to find the early tumors, the ones that are much more readily treatable. Lung cancer, if symptoms arise, is usually in a more advanced stage. So we want to find tumors that have no symptoms at all. And the only way we're going to do that is if we look. And CAT scans have developed to a point where there's low radiation exposure, low relative cost, low relative time. And that's the best way for us to see through the lung tissue for any abnormalities. Joan, I don't know if you want to touch on our screening program at Cape Cod Healthcare.
Sure. Thank you very much. So the lung cancer screening program that we have at Cape Cod Healthcare provides a low-dose CT on an annual basis to folks who meet the United States Preventive Services Task Force guidelines. What's important to remember with lung cancer screening in our country is, right now we have about 23 million people who are eligible for screening, and only about 5 to 10% of folks take advantage of this screening, which, again, we're really trying at Cape Cod Healthcare to really promote this. So if you're between the ages of 50 and 80 and in relatively good health, and you are a current or a previous smoker with at least a 20-year pack year smoking history, and you've quit within the past 15 years, you are eligible annually for this low dose cancer screening. And our primary care doctors here at Cape Cod Healthcare, as well as the ones in the community, can help you obtain this. You sit down with them and do a shared decision making, which also involves, if you haven't quit smoking, to talk about smoking cessation programs that are available to you, whether it's a program or a medication. So we really encourage you to have this conversation with your primary care. For those of you who have primary care through Cape Cod Healthcare, your primary care can order this very simply through Epic, and it can get scheduled within a month or so. So we are really encouraging anyone who meets this criteria. Of note, which is kind of a good thing, Massachusetts has the highest lung cancer screening rate, and it's at 16%, but that's actually the highest in the nation. So we'd like to see that number go up a little bit more. The role of that I have as the navigator in lung cancer diagnosis comes after you've had this screening CT, and if there is a concern, what will happen is your primary care will get notified of your lung cancer screening results, and if it is in need of further workup, where there's a concern that this might be cancer, they will direct you to the lung nodule conference. And what we do is we look at the CT as a group, as Dr. Spillane mentioned, weekly, and decide that if the patient needs to go through with further testing, whether it be a PET scan or a biopsy, and we help expedite this so we can complete the workup. We also can answer questions for patients and family during the workup, and it's also a time where we can look to see if there's some community resources that you may need, things like rides to testing, rides to doctor's appointments, and really sort of identify any of those barriers so we can get you in and get you seen. I also act as a liaison between the oncology team and the primary care. And basically what the goal is to get you to the point, if it's needed, to work up and get you to oncology as quickly as possible. And then just to sort of clarify, this is really a team effort. So it really requires everyone in the community working together to help get early detection for lung cancer. We really rely heavily on our primary care physicians to help identify those folks who may meet criteria. Certainly any symptomatic issues that people may have that may warrant a CT scan, getting that done and getting a referral in to the lung nodule conference is key. But we also, through our lung cancer screening program, provide surveillance of folks who may just need annual follow-up and make sure that they don't follow through the cracks and come back and have those annual screenings. And then really looking at, again, this screening is provided for folks free of cost if you meet the criteria for the lung cancer screening, making sure that you can get to that appointment and have that screening done. But it really is a team effort for all of us to get these folks identified and moved along.
So I just want to reiterate what Joan said. She's also very humble. We're extremely blessed to have her as a team member, but she is really there for the patients. So what was said is we know that we underscreen folks nationally, that only a small percentage of the people who are eligible have actually undergone CT screening. We work real hard, this is part of it, to encourage people. If you have a smoking history, you'd be surprised, even though you quit years ago, between the age of 50 and 80, to worry about this just enough to get a screen, just like you get a mammogram or colonoscopy. Nobody, it's part of modern healthcare. We find things early. We find things before they're symptomatic. Joan is an enormous resource for patients and families to get people who get a scan that, it pops up on my chart probably that evening. And we try and identify those folks as early as possible and really help get them through the process quickly. So I can't thank her enough for both being here tonight, et cetera. We're on track for what, 2,700 screenings this year, I think, something like that. So what happens with an abnormal CT finding? Those scans, again, are flagged to Joan, and almost immediately she's pulling in either Dr. Ayers or myself. But then we meet weekly to review those abnormal CTs. We partner with radiology. We've got some great radiologists who help us. Even though the scan has been read, we try and put it in context. At that point, we've had a chance to kind of understand the patient. And then we say, how best can we get this abnormal scan to the appropriate people? Most of the time when you have a CT, there may be an abnormality, but hopefully it's just an abnormal small amount of bronchitis, some distant exposure to a fungus or other granulomatous process. But obviously we want to make sure that things are not a problem. But there are a lot of incidental findings which do take sorting out, can produce anxiety for the patient. And again, that's where Joan comes in. And the big thing we can do to help relieve anxiety is get the patient seen, get the appropriate tests, and move on with things. So we meet weekly to review the abnormal CAT scans. There are a number of scans that are done, say in the emergency room, somebody comes in for some other problem. They may have fallen, cracked a rib, and sure enough, we find a problem on there. We walk through that, what's known as the LRADS criteria, kind of a scaling of abnormal scans. And on the alarming scans, we get them seen, and then we go to the next steps. Joan's immediately trying to get back in touch with the primary care or the folk who ordered the scans, as well as the patient, to get them seen by the appropriate folks. I think I'm just going to go through that. So is it a real problem, or is it just simply a small amount of collapse of the lung? Has it spread? And that's where PET scans come in. That's a metabolic test that is very similar to a CAT scan, but it shows us areas that are particularly of concern. We do brain scans when we think we have a definite tumor, in part to make sure that it hasn't spread to the brain. But our modern approach is, this is tissue. We need tissue so we can look at, is this a genetic issue? Is it susceptible to some of our more modern therapies? There are many different types of lung cancer in the lung cancer spectrum. And the more modern approach to this is to really kind of individualize the patient, individualize the tumor. What about this particular patient led to this particular tumor? And how can we best treat that? We have a number of treatment options. We'll come back to that in a minute. I'm going to hand it over to Dr. Ayers for sort of the workup from the abnormal CAT scan, excuse me.
Thanks, Jeff. So I'm going to kind of change directions a little bit here and get more into more procedure-related diagnostic procedures that we do here. When we find abnormal findings on our low-dose CAT scans, on our regular CAT scans, just that find incidental findings. In this particular case I'm going to work through with you, on this CAT scan, we see a relatively small nodule in the left upper lung here. The yellow arrow is pointing to that. So this is a relatively concerning nodule. And in fact, this is not the actual first CAT scan for this patient. This is the second one. The first one was about 8 months prior to this one. The nodule at that time was about 6 millimeters. It's now, in about an 8-month period, increased in size to 11 millimeters. So the reason there was an 8-month interim between the two scans is this patient had multiple medical problems. Actually, was hospitalized a number of times, required some surgeries, and then some rehabilitation time in a facility. And so what we had decided when we first saw his initial CAT scan was with the 6 millimeter nodule, probably too small to do anything about. We were somewhat concerned that it was probably going to be a cancer, but we needed more information to make that decision. And these are the kind of things that we go through when we see these patients. We obviously have to meet with them, go over their medical problems with them, go over their history, the appearance of the nodule, and weigh all that and come up with a decision with the patient of what to do next. And that can be anything from watchful waiting, meaning we might not do anything right away. We might just get another CAT scan down the road. Usually a 3 to 6 month CAT scan if we're concerned about a possible cancer. We might proceed to another test, a PET scan, which will also give us some information, help us in the process of helping us decide what to do next for these patients. PET scans are not perfect tests. They're not diagnostic tests. They don't confirm cancer in patients, but they're helpful. They do provide helpful information for us. And if the nodule lights up on a PET scan, that's somewhat helpful. But PET scans, unfortunately, are not specific. There are other things that will light up on PET scans other than cancer. So in this particular patient, we waited 8 months, got another CAT scan. The lung nodule increased in size. He's a smoker. Increasing size of a nodule is very concerning for cancer. So we opted to do a PET scan after I had a discussion with him. And so that's shown here on this side, on the slide on the left, probably the right as you're looking at it. But this kind of black and white scan with the broader yellow arrow pointing to a kind of a bright white nodule, that's the PET scan. And that is activity. That's positive activity on a PET scan. So that's concerning. Again, growing nodule in the smoker with PET activity, that's a lung cancer until proven otherwise. He's not a great surgical candidate because of all of his medical problems. So again, we had a discussion what to do next. Usually at this point, we're either going to do some form of a biopsy. Sometimes in the right surgical candidate, that patient might actually meet with Dr. Spillane and actually have a discussion about maybe having surgery up front. But again, this patient wasn't a surgical candidate. So the next step was to do a biopsy. And there are options in what to do as far as biopsies are concerned. At this time, I opted to go with a interventional radiology CT guided biopsy because at this time we did not have the bronchoscopy type procedure to go after this, but there are options with a bronchoscope as well, and I'm going to get into that in a minute here.
So again, Mike, this is 11 millimeters or so at this point.
11 millimeters.
This patient would not have any symptoms that we could expect. The only way you're going to see this is with a CAT scan. 11 millimeters is about a half an inch in diameter. The needle track for the biopsy is actually seen on the far right. Is that correct?
Yeah, right. So the next scan next to him is actually the procedure CAT scan that he had here in the radiology department. One of our interventional radiology colleagues used a needle to biopsy this nodule, and you can actually see the needle. There's a thin white line going into the nodule, biopsying it. And that's how we made the diagnosis for this patient. Again, not a surgical candidate. We got a diagnosis of cancer, and he had appropriate treatment. Again, and Dr. Spillane will talk about our treatment options. So that leads me to the next topic, and this is one I'm happy to report that we now are able to offer a form of bronchoscopy to go after these small peripheral, difficult to get to nodules, other than just doing CT-guided biopsies. So, and this is what we call robotic bronchoscopy, a form of navigational bronchoscopy. We'll be starting this in the next month, certainly within the next couple months. This will be available here at Cape Cod Hospital. So the slide on the left there shows the actual robotic bronchoscope. There's a stand that the operator will work from to operate the bronchoscope, and then a monitor up above there kind of follow and see what you're doing with the robotic bronchoscope. On the right is the typical scene in the operating room for this procedure. So this is a procedure that we would perform in the operating room. Patients are not awake for this. They are out under general anesthesia. It's a pretty involved procedure. Many people in the room, all working together, using that bronchoscope to get out to a peripheral nodule. It does involve radiology. We have live fluoroscopy, and there will be a cytopathologist in the room looking at specimens. An anesthesiologist is in the room as well as all the operating staff, and then the person performing the procedure.
No incisions for the patient, so it's really as minimally invasive as you can get. And we're very fortunate. The administration helped us with this because this really is the future of care. The computer mapping of the airway tree is phenomenal, and it allows us to get almost anywhere within the lung tissue, even to the small nodule that you saw earlier.
Absolutely. So this next slide is actually showing the mapping portion of the procedure. So before we do any procedure through a computer software system, we're able to locate a nodule or a target to go after, and then the computer and the operator can actually develop a pathway to that difficult to get to small nodule. And that's depicted by the very blue thin line down through the airways going to the nodule, which is in this case in the upper left lung, and it's a green dot there. So once we map out a target and have a pathway, we can then do the procedure. And this is what the screen would look like during the procedure. Again, in this particular case, there's a right upper lobe nodule, very difficult to get to, not a typical nodule that we would ask a radiologist to go to. It's pretty deep in the lung. It's a lot of normal lung tissue they would have to go through to get to that. So this is really a classic typical nodule that we would use robotic bronchoscopy to go after. The lower screen there shows that we've already driven out to the nodule, the target. The target is that big green ball. We can then confirm we're there once we're at the target using a radial EBUS probe, so ultrasound probe, which confirms that we're actually in the tissue. And then under live fluoroscopy, we can then start sampling that nodule.
So even though that's a very small nodule, these are the ones we want to find. These are the ones we can make a real difference. If we find something that small, this is easily treatable in the vast majority of times. So smaller is better in this case.
So just now changing topics a little bit, we've been talking about small nodules. We've been talking about those kind of targets we want to find when we're doing low-dose CAT scans, obviously trying to find lung cancers early stage. So as Dr. Spillane just said, we want to be able to cure people. We want to be able to treat them effectively. And so the smaller, the better. But unfortunately, these scans that we do look at don't always show early stage cancer. Sometimes, unfortunately, we see advanced forms of lung cancer. And so that's where another procedure that we perform here at the hospital called endobronchial ultrasound, or EBUS, is very helpful. So for those larger masses that are more central, easily accessible off airways, or if there's lymph nodes involved. And so unfortunately in advanced lung cancer, many times we do find patients have enlarged metastatic lymph nodes. This particular procedure allows us to not only sample the lymph nodes, but also sample those more central larger masses. So on the left there is our bronchoscopy cart that we use in the operating room. In the middle there is the actual bronchoscope with a needle catheter in the scope, and then in the bottom center is the distal end of the scope with the ultrasound probe, and actually see the needle that we would use to sample lymph nodes or masses through the scope. This too, like robotic bronchoscopy, is a procedure performed in the operating room. Again, patients are out under general anesthesia. And it's the same day procedure. They come in, get the procedure. Usually, thankfully, this procedure is relatively safe. Patients tolerate it pretty well, and they get to go home afterwards. This is an example of advanced lung cancer. Unfortunately, this patient has a large right hilar mass, and then in the central part of the airway there, just off the trachea, you can see an enlarged lymph node. This is a classic good case for us to use EBUS in, and on the right side there, we have a ultrasound picture of both the needle in the lymph node in the upper portion, and then in the lower portion, the needle in the mass itself. So really a nice tool, very useful tool in making a diagnosis, not only able to sample lymph nodes, but also masses themselves, and provides ample tissue for the diagnostic workup that we need. So I'll turn it back over to Dr. Spillane.
So even on these larger tumors, I do want to make the point, the stigma around lung cancer is generations old, but the treatment options available in 2024, 2025 have really changed. We're making a big difference even in these larger tumors. And I just kind of want to go over some of the modalities there, and then we're going to open it up from questions. But so yes, as Dr. Ayers had shown, this is a advanced lung cancer, and 30 years ago that would have been a significant problem. But our treatment modalities have changed a lot, and so we're working real hard on that. We have a number of questions coming in, so let me just go over some of the options available for treatment. I'm a surgeon, but my radiation oncology colleagues have much more modern radiation oncology techniques, one of which is stereotactic radiation. The machine on the left actually spins around to deliver a small dose of radiation from multiple different areas to put a very concentrated dose right on the small tumor that you see highlighted. Those are radiation fields. There's not a lot of surrounding damage with that. Very frequently used for people who are not candidates for surgery. I met somebody today who was 89. We're going to get them rolling along. Now, there's 89 and 89, but they're pretty good at 89. We want to keep them going. Ablation therapy, also, we're very blessed at Cape Cod Healthcare to have very good ablationist, interventional radiology. The tip of the needle specifically can heat up with microwave to provide a very precise dose of treatment. If we can get a needle in the middle of tumors like that, we can help quite a bit. I'm a surgeon. We've moved traditionally away from the large rib spreading operations to thoracoscopy, and then for the last 10 years, I've been doing a robotic approach. Smaller incisions, less pain, less inflammation, home quicker. It's really been the way to go, and I'm really amazed at the results that we get with the more modern techniques. Finally, if it gets past kind of local therapy, immune therapy is the real future of oncology care, and we are rapidly expanding in the last several years. Immune therapy does not boost somebody's immune system. It exposes the tumor to the immune system. This particular picture shows Keytruda, which I think we've all seen advertised on the nightly news. But the field of immunotherapy has really blossomed in the last several years. We're rapidly expanding it. There's more and more treatment options coming available and online. I think that's where we're really headed for the more advanced stages. I'm going to open things up to questions.
What is the actual low-dose CT screening procedure like? How long does it take? And is there anything I need to do to prepare? I can answer that.
Sure.
Okay, that was good. So the actual screening procedure takes about 25 minutes to come into the hospital. And there's nothing that you need to do to prepare. There's no fasting or anything like that. It takes about 25 minutes to do the whole scan. And again, it's very simple. Our lung screening coordinator, Christine Gould, is available, and she is, great about scheduling, answering questions, really accommodating folks with things like work. They're done at the hospital at, Monday through Friday, Saturdays, really any day you can come in, they will take you in for the cancer screening.
And when I talk to patients, they're really amazed at how quick it took. You simply lie there, you slide through a machine. It's not a claustrophobic environment. It's a low dose of radiation, almost equivalent to the old chest x-rays. So, yeah.
No IVs, anything like that. So pretty simple test. Not like the MRIs, no loud banging or anything like that. How often should at-risk individuals undergo lung cancer screening?
Well, I can tackle that, or Mike. One of the things I would say is when we first started screening folks, we weren't sure how beneficial it would be. And if you really follow the history of this over the last 10 years, we've expanded our screening where it started at age 55 to 74. Now it's age 50 to 80 plus. And we do screen people over the age of 80 if we think they're going to be around and there's no other health issues. So the recommendations would be to do at least a screening every year for 3 years at minimum. There's a lot of people who I follow who we just do every year, and that's their annual, just like an annual mammogram. As Mike showed earlier, we had somebody with a very small nodule. We looked again in a few months, and that nodule had increased to 11 millimeters.
Okay, next question. Beyond smoking history, are there other lifestyle or environmental factors that should prompt someone to consider screening? Mike?
Yeah, I've been touched on it. You guys feel free to add. There are other things, but unfortunately, they're not really included in the lung cancer screening criteria. But radon exposure is a big concern. Asbestos exposure would also potentially lead to cancer, mesothelioma. But unfortunately, they're not really part of the criteria for low-dose CT scanning and lung cancer screening.
What we have seen over the last several years is that the traditional association between smoking and lung cancer was always there, but there were so many people who had smoked that hidden in the background were the more genetic family history lung cancers. And we have seen an increase in non-smoking, often female, like the adenocarcinomas, these early tumors. But again, if we find them early, that's the easier ones to do it. But there's certainly family history. It's very hard to pick apart that, right? When the dad smoked and the mom smoked and then you smoked, is that family history or not? But we certainly, our ears perk up when we hear about cigarettes, we hear about family history. Radon, as Mike touched on, the Connecticut River Valley, we've got a number of patients on the Cape who grew up in that area. It's around and it's a background.
And then I just also want to say, Christine Gould and I have attended the first responders annual meeting the last 2 years. And there is, if you are in police or fire, and there's exposures there are low-dose screenings available to our first responders through a state program. Unfortunately, we are not a provider at Cape Cod Hospital. We are looking into that the next time it becomes available, but that can be done for our first responders who are concerned with any environmental exposure from their jobs. Okay, next question. How do low-dose CTs scans compare to other diagnostic tools in terms of accuracy and patient safety?
Well, I had showed that lung cancer trends earlier, and again, screening was explored in the 1970s. Chest x-rays are just not that accurate. They're a good initial step, lower dose radiation, easy to do, but with the ribs and the heart shadows, there's a lot of shadowing that occurs with a chest x-ray, and a CAT scan is our most reliable. So we do use ultrasound in the belly because, like, the liver is a solid organ, sound waves transfer through there. The lungs are mostly air, so ultrasound doesn't seem to work too well for lung tissue, although when Dr. Ayers is doing an endobronchial ultrasound, he's inside and he's looking at the soft tissue, and there we can use ultrasound, but it's not a good screening tool. There's a new trend towards patients paying for their own MRIs of the body. I can't even touch on that. I haven't had one. I don't intend to have one. I think that's I don't know where we're going with that, but people are selling MRIs. I would not encourage that.
All right. Next is the lung cancer screening covered by insurance? If you meet the criteria for the lung cancer screening, it is absolutely covered by insurance. Certainly, if you're symptomatic or you've had a history of lung nodules, that is also covered by insurance, which would be more of a follow-up type scan. Once a lung nodule has been identified, it would be covered by a scan for rescreening, especially if we noticed, as Dr. Ayers was mentioning, about changes in size of lung nodules. So yes, it is covered by insurance.
And one of the reasons insurance companies agreed to cover it is it's cost effective. If you can find a problem, deal with it early, it's cost effective. We don't let that get in our way if somebody needs it. But again, the criteria are out there, and you should meet those criteria. You should have had a smoking history age 50 to 80. There's no point in screening a 25-year-old. The risk is very, very low.
What is your advice to someone who is trying to quit smoking? How do I start?
Come on. We were talking about this right before the podcast or webinar. It's hard to quit smoking, right? Don't start smoking. Nicotine is a highly addictive substance. There's not one size fits all. There are programs out there. The American Lung Association, American Cancer Society have that. I'm a pragmatist. I know that smoking exposure, the more you smoke, the more risk you have. If you can cut those cigarettes down. I have met people who smoked for a number of reasons through the years. I started in a military, our veterans smoked for reasons that were very understandable. I've met people who started smoking at the age of 12. They didn't make a conscious choice. There are a number of reasons to start, but once you start, hard to stop. Admit you have an issue, work on it, chip at it, decrease your dosing by cutting them down. Yes, if you can quit cold turkey, there is definitely habit issues. Every smoker I've ever talked to has a cup of coffee on the back deck first thing in the morning with a cigarette. They look forward to that. That's a habit. If you can break those habits, you got to clean the ashtrays. You got to get the stuff out of your car. Tootsie Pops, the gums help. For established adult smokers, e-cigarettes have a role. They marketed it to kids to get a new generation going. I am vehement about that. However, for established smokers, e-cigarettes do have a small role. I don't know, Mike, if you have any other.
I agree with everything you said. The one thing I've learned over the years of seeing smokers is, every smoker knows they shouldn't smoke. It's just hard for them to quit, as Dr. Spillane is saying. But everybody knows in their heart they shouldn't be smoking. And what I tell them, and I can't tell you how many people come in and say, look, I need help. I just can't quit. The only way I think most people can effectively quit smoking is they have to come to the conclusion themselves that it's time to quit. They have to have the willpower. If they know in their heart they're not ready to quit, they're going to quit, it's not worth even trying at that point, because it doesn't work for people. Despite all the help out there with Nicorette, nicotine gum, the patches, Chantix, Wellbutrin, if you in your heart don't really understand and want to quit, it's probably not going to happen. So I always tell people, look, in order for you to effectively quit smoking and maintain it, you've got to want to quit smoking. It's got to come from your inside to enable you to do that.
But what I will say across our system, within our team, within our larger oncology team, the stigma issue and the kind of, we don't play the blame game. It is what it is, right? And we recognize that people have started for various reasons, and we just work from there, okay? Yes, healthier lifestyle, absolutely. We want to help you on that. That's why we're here tonight.
Okay. What are some of the most common incidental findings?
That's a great question, because obviously we've been talking about lung cancer here, and that's the goal of getting the low dose CAT scans. But the reality is we find so many incidental findings, not cancer related. So think about it. We're doing a CAT scan basically from the neck to the upper abdomen. We're finding thyroid nodules. We find things in the soft tissue in the chest wall. We find aneurysms in the aorta. we find liver problems, kidney problems, all that can turn up on these scans. So yeah, the goal of the scan is obviously trying to pick up lung cancer early, but we are finding other things that we can actually act on and impact patients on it. So for example, we find an aneurysm, that's important, and we can direct them, and that's the goal of these scans. Just because there's incidental findings, we're not just concerned with lung cancer. If there are other incidental findings, we get you directed to the other specialists that you might need to see.
So just to review things, screening programs exist because we can make a difference. Our goal is to find stuff early. We know that nationally and even in Massachusetts, we're only screening a small percentage of the people who are eligible. But if we haven't answered your question tonight, you can email us at outreach@capecodhealth.org, and we will try and get back to you individually. I'm sorry if we didn't have time for that.
Thank you, everyone. Have a good night.